Good afternoon, ladies and gentlemen. Today I want to read a lecture that called Benign Prostatic Hyperplasia. This pathological has long been known, and benign prostatic hyperplasia is described by ancient physicians such as Avicenna, Paracelsus, Hippocrates, and others. From anatomy and top anatomy, you know that the prostate is a small gland present only in men which about the size of a chest heart. This prostate lies below the bladder and fits around the urethra razor-like collar. We can see these organs. The prostate depends on the testis functions normality of its normal growth and development. What are the organs? How we have these organs? The prostate produces a fluid which forms a part of semen. During the sexual intercourse, sperm passes from the seminal vesicle, you can see, into the urethra and carry out through the urethra in fluid squeezed out from the prostate gland during orgasm. The rest of semen is stored in the periseminal vesicle, which is just behind the prostate. If we have normal diameter of the prostatic part of urethra, we haven't problem with the urination, but sometimes from the age, more than 50% of men over the age 16 and 80% of men over the age of the 18 have benign prostatic hyperplasia, and we have compression the prostatic part of the urethra. The doctor calls it pathological benign prostatic hyperplasia. The prevalence of symptomatic benign prostatic hyperplasia increases with the age. And in this picture we can see if we have age 14, 48, 9-year-old, from the histological examinations we find only 10%, and if we use digital rectal examination 27% of the time. But if we have 1669 from the histological and history physicians the complaint, we have pathological more than 40%, but if we use digital rectal examinations, we find more than 70% of all cases, and increase from the age. The prostate sometimes from the age compress the prostatic part of the urethra, enlargement, and start to press the urethra part. After that, urethra becomes narrowing, and from that sometimes we have problems that called acute retentions or chronic retentions. In this picture we can see complications that cause to the compression of this prostatic part of the urethra. It's a thinning urinary bladder wall. We can see sometimes diverticule, also maybe formations the stone because problems output of urea, also ureterohydronephrosis. And from the future we will have problem with kidney, chronic renal insufficiency, chronic pyelonephritis. From the etiological factors that depend from the race, geographic, genetic form factors, hormonal reasons because testosterone passed to the dehydrotestosterone from the alpha adrenal blockers, and stromal epithelium interaction, stem cell theory, apoptosis decrease. In this picture we can see how the normal part passes to the benign prostatic hyperplasia and compress the prostatic part of the urethra. In what situations patients go to the doctor? If we have good stream, good urinations, not frequent, we never go to the doctor. But sometimes from the age, the patient feeling problem with the urinations, problem with the output of urea. Sometimes it's a frequent dysuria. Sometimes the patients go to the toilet at night that called nocturia, and others. In these situations we will go to the doctors. What are the main symptoms of benign prostatic hyperplasia? Interruption in the urinary stream, hesitances before beginning to urinate, terminal dribbling, an urgent need to urinate, frequent urination, especially at night, that called nocturia. Sometimes the patient's feeling that the bladder is still full after urination. It's called chronic retention, weak urinary stream. That's why the main symptoms we have a problem with the lower urinary tract, and it's also independent from the effect on quality life. A restrict fluid intake, lack of sleep, unable to play sports, limits visited to the cinema and traveling, causing embarrassment, leads to worries about cancer, limit travel. It's problem also from the family, because if the patients go to the toilet 3-4 times at night, it's nervous patients, it's never want to sexual life, it's problem from the wife and problem with the family. What complications benign prostatic hyperplasia? Very often it's a urinary tract infections, maybe chronic, maybe acute. Also, acute urinary retentions, more than 60%, hematuria, micro or macro, chronic kidney insufficiency, bladder stones, upper urinary tract dilatations. Sometimes, if we have acute retentions, it's complications. Very often we find these complications. We can see that the urinary bladder filling, tympanate if we use percussions, and we must pass catheter to the urinary bladder from the drainage of this thing. Sometimes it's problem with the catheterization by the elastic catheter. That's why we use catheterization by metallic catheter. We pass metallic catheter, its specific modifications, to the urinary bladder. Okay, bladder problem. I said that enlargement prostate has been pressing of the urethra for a long time. The back pressure can eventually damage the bladder and also less commonly affect the kidney. It forms the bladder stones, it's urethral hydronephrosis, it's thinning parenchyma, it's ascendant pulse infections, and also chronic renal insufficiency. In this scan, we can see the pathologicals. What classifications? In Ukrainian country, we have classification from the 3 stage: compensations, subcompensations, and decompensations. But in European and American country, we give for patients specific enquetes that have it's called IPSS score. What is it IPSS score? It's International Prostate Symptom Score, where we have 7 questions and 5 answers the questions. If we have bell between 0 to 7, it's mildly symptomatic. It's same if we compare with the Ukrainian classification, it's the first stage. In Ukrainian classification, in the first stage, we haven't chronic retentions. In the second stage, subcompensations, we have chronic retentions. How we studied these chronic retentions? In the patients, we use catheterizations after urinations, and we use ultrasound examinations after urinations. If we have 100-200 milliliters chronic retentions, we put second stage. And third stage is the decompensations. If the patient has specific complaints that called ischemia paradoxum, if the urinary bladder filling, and we have incontinence. And also in the blood analysis, biochemical blood analysis, we have increased level urea and creatinine. You remember that level creatinine 0.1 millimole per liters and urea 8.3 millimole per liters. If the level increase, we put sad stage. It's same. Fast stage 0 between 7. If we compare with the International Prostate Symptom Score, 8 to 9 moderately symptomatics, and between 20 to 35 it's severely symptomatic. If we compare with Ukraine, it's a sad stage. What diagnostic program? First of all, we use International Prostate Symptom Score. We give enquetes and the patients give answers the questions, and we understand what the problem, what obstructions and what irritation symptoms. Next step is specific marker from the cancer of the prostate. It's a prostate-specific antigens. We take blood analysis from the vein, and we started towards the level PSA test. Next step is a digital rectal examinations. With the finger, we use digital rectal examination. Now I will stop from this moment. Sonography, transrectal sonography, urodynamic, ureterocystography, intravenous pyelography. What is the prostate-specific antigen? It's protein produced by cells of the prostate gland. The PSA test measures the level of PSA in a man's blood. For this test, a blood sample is sent to a laboratory for analysis. The results are usually reported and nanograms of PSA per milliliters. At normal, the average normal level is 4 nanograms per liter, but sometimes it's independent from the age. It's also independent from the size of the prostate gland. Sometimes we use prostate after sexual life may be increased, after some inflammatory, but you must understand that the average between 3 to 4 nanograms. Physical examination to be assessed. Suprapubic area to rule out significant bladder tone, sphincter tone, bulbocavernous reflex. Digital rectal examinations. We palpable the prostate, what the consistency of this prostate, shape and abnormality is suggestive of the prostate. It may be suspect cancer if we palpable some hardly consistent, maybe sometimes not moving rectum about the prostate. And also we know what size, because if you know that the size of the prostate 2 to 3 centimeters and you palpable enlargement prostate on 5 to 6 centimeters, 6 to 7 centimeters, we suspect maybe the patients have benign prostatic hyperplasia. No interpretations as a result if you use digital rectal examinations. If this finger palpate every day 10, 20 prostate, and for my opinion, I know that what I suspect, maybe chronic prostatitis, maybe benign prostatic hyperplasia, maybe cancer, maybe stone in the prostate, maybe abscess of the prostate. It's from the practical, you will know. Next step, it's a urinalysis. If we have problem with the urinations, if we have difficult urinations, maybe chronic retention, in all cases we have hematuria, proteinuria, pyuria. Also, I said in the sad stage, if we have increased level of the urea and creatinine, should be determined by serum creatinine test, because we will have clinic renal insufficiency. Urofluorometry, it's a non-invasive technique. It's recommended in the initial diagnostic assessment and whenever appropriate during and after treatment to determine a response. We started maximal urinary flow rate, is the best single measure, but below EQ max does not distinguish between the obstructions and decreased bladder contractility. Ultrasound examinations, non-invasive methods that give for us good information. We use this method if the urinary bladder filling. We can see size of the prostate, how spread to the urinary bladder. Also, with diagnostic thinning wall of the urinary bladder, sometimes we find stone in the urinary bladder, tumor mass. Also, very important moment, we studied if the patients have chronic retentions or not. That's why after examination the patients go to the toilet and we studied if we have retentions or not. Before 20-25 milliliters it's normal, but if the retentions more than 25-30 milliliters, we write down that the patient have chronic retentions. For example, 50 milliliters, 100, 150, maybe 500. It's measure these examinations. Very good examination is ultrasonography transrectal, because give for us maybe some part where is the hardly consistent, maybe some suspect mass, suspect from the cancer of the prostate or stone. X-ray examinations. We use a retrograde cystography. We can see filling defect, right filling defect in the neck of urinary blood. Next, maybe excretory urography. We studied anatomy function ability, and also from the late minutes we can see specific symptoms that called fishing hook. Lower part of the urethra deviations, you can see, it's called fishing hook and filling defect. In this picture we can see classic fishing hook. Urinary benign prostatic hyperplasia enlargement, compress the lower part of the urethra, and this part of the urethra deviations, and the similar fishing hook. Endovesical examinations. Very simple method is the cystoscopy. What we can see? We can see enlargement lobe that deformate the neck of urinary bladder. In Ukrainian, sometimes we call symptom bat-katan if we have two lobes. Also, we can see sometimes the trabecula, also maybe stone. Its complications, benign prostatic hyperplasia. CT, MRI, expensive methods, but from the deep diagnosis between the cancer of the prostate, benign prostatic hyperplasia, sometimes we use these methods. In this picture we can see enlargement prostate, benign prostatic hyperplasia. Differentiated diagnosis. If we have problem with the lower urinary tract, there are 10 symptomatic, maybe give for us clinic problem with the lower urinary tract. For example, chronic cystitis, tuberculosis. If we use endovesical examination, sometimes we use deep diagnosis. In all cases, if we have, for example, stone disease, tuberculosis, chronic cystitis, foreign body, stone in the urinary bladder, cancer in the bladder, chronic prostatitis. In all cases, we have frequent urinations, difficult urinations, maybe banning in the urinations, nocturia, not filling urinary bladder, and others. And if you use additional methods, for example, endovesical examination, if you use cystoscopy, we can see trabecular, diverticle, specific clinic, stone in the urinary bladder, tumor mass in the bladder, gray hump with the hyperemia, it's specific from the tuberculosis, and a foreign body. In all cases, clinical the same. If you use retrograde cystography, X-ray investigations, for example, small volume of urinary bladder, vesico-urethral reflux, specific from the tuberculosis, stricture of the prostatic part of the ended portion of urethra, pneumocystography give us non-radiopaque stones situated in the urinary bladder, diverticle, spread contrast material above the urethra, trauma, and cancer, not regular filling defect in the right part of the urinary bladder. That's why cancer we suspect. What treatment? It's very interesting because from the last century, 2 centuries ago, we used only operative treatment. But now we use wageful tactics, we use medicamentosus treatment, mini-invasive, open operation, transurethral operation, and others. It's independent from the size of the prostate, from the clinic, from the complication, from the health of the patients. From the drugs, wageful tactics. If we have very poor symptomatic, sometimes we use wageful tactics. Medicamentosis, what drugs? It's use alpha-1 adrenal blockers, 5-alpha reductase inhibitors, and combination of both types of drugs. Mini-invasive, it's a prostatic stents, transrectal hyperthermia, transrectal thermotherapy, laser therapy, high intentional focus, and surgery, transurethral incisions, transurethral resections, and open prostatectomy. Now we have very different modification of treatment from the conservative treatment. First of all, I want to start from the alpha blockers. We know that alpha receptors situated in the neck of urinary bladder and prostatic part of the urethra. Alpha blockers are drugs that can relax the smooth muscle of the prostate. This reduces the pressure on the urethra and provides relief from some of the symptoms caused by the enlarged prostate. Treatment with alpha blockers usually improves symptoms within 2-3 weeks. Altogether, about 60 to 75% of patients gain some benefit from these drugs. It's different drugs, for example, it's Cardura, Omnic Ocas, and others. Sometimes we have contraindication to prescribe these drugs, but after some minutes I want to stop. Next groups, it's inhibitors 5-alpha reductase. We know that male hormone that produced in the testes, it's called testosterone. Testosterone pass to the ferments 5-alpha reductase to the dehydrotestosterone, and dehydrotestosterone stimulate the enlargement prostate gland, enlargement benign prostatic hyperplasia. And specific drugs, inhibitors 5-alpha reductase, stop pass testosterone to the dehydrotestosterone. If we haven't dehydrotestosterone, we haven't stimulation, enlargement the prostate gland. Inhibitors 5-alpha reductase, for example, it's a drugs Proscar, company Merck Sharp and Dohme give us these drugs, but effect after these drugs only after 6 months and only 70% of all patients. What contraindications to medical treatment of benign prostatic hyperplasia? If we have acute urinary retentions, if we have chronic retentions and residual volume more than 250-300 milliliters. If we have sad stage of the benign prostatic hyperplasia and if we have renal insufficiency, it's also contraindication to conservative treatment. Recurrent hematuria, recurrent urinary tract infections, bladder stones or diverticle if we have complication benign prostatic hyperplasia, and evidence of prostate cancer. Non-invasive methods include transurethral laser intestinal ablations, transurethral laser needle ablations, transurethral microwave thermotherapy, high-intensity focused ultrasound, intraprostatic stents, and operative treatment. What indications? Medications conservative treatment is ineffective. Residual urine more than 200-300. Reparative urinary retentions, upper urinary wave dilatations, hematuria, recurrent urinary tract infections. We use transurethral prostatectomy, it's a gold standard from the last century, transurethral incisions, and open operations. What is a transurethral incisions? If the patients have very poor health and maybe after some complication with the heart disease, with the decompensation of the vessel systems, the gastrointestinal systems, we use simple methods. We pass transresectoscope to the urinary bladder and use 2-3 incisions. It's a simple operation carried out under the general anesthetic, which only takes about 15-20 minutes. The procedure involves passing an instrument of the urethra and making 1 or 2 small cuts in the bladder neck. But we use 3 cuts. These cuts allow the prostate tissue around the urethra to spring apart. This reduces the pressure of the prostate on the urethra and makes it easier to pass urine. During the operation, a catheter will be passed up the urethra into the bladder to drain off the urine. This will be removed after 28 hours. You will usually be able to go home after 2-3 days. The gold standard, I said, it's a transurethral resection. It carried out under the general anesthetic and usually takes about 60 to more or less than 60 minutes. Transurethral resection involves passing an instrument that called resectoscope up to the urethra and cutting away the middle of the enlarged prostate. During the operation, a catheter will be passed up the urethra into the bladder to drain off the urine. This drainage we put from the 2-3 days, and after 3-4 days will be need to take like water for a few weeks. After operations, we prescribe antibiotics and also alpha-1 adrenal blockers, spasmolytics, and other drugs. We can see the operations room. The doctor sits with a resectoscope. We can see monitor. On the monitor, we can see 2 lobes and seminal vesicle from the control, because we remove this tissue before seminal vesicle, because if we remove these positions near the seminal vesicle, maybe we will have complications that called incontinence. Step by step, we remove the tissue, left lobe, right lobe, and middle lobe. Now we can see film transurethral resections. First of all, we use cystoscopy. After visual control, we start step by step remove by the loop this tissue. Use resections, and sometimes if we have bleeding, we use coagulations. We can see how we use step by step resections the tissue. with your control where situated seminal vesicle. Small bleeding, we remove teeth and also use correlations. Sometimes, if we have a big size of the prostate, more than 100, 150 volume, we use open operations. There are different also modifications these operations, such as retropubic prostatectomy. In my clinic, we use open transvesical. We remove the part of the all. We remove all prostate, and after that, we suture this part from the stop of bleeding, and sometimes we pass catheter fully from the compress this part. You can see how we remove the tissue. After that, this tissue we pass to the histological examinations, and if we know if this is benign prostatic or cancer. Very easy methodical. It's a prostatic stents. It's a small metallic coils that are inserted into the urethra to hold the walls open. Two types of stents are available. It's a temporary and permanent. Transrectal hyperthermia. It's a non-invasive methodical. Use microwave energy to destroy some of the prostate tissue by hand. The procedure is carried out without anesthesia and takes about 60 minutes. Transurethral thermotherapy. In my department, we very often use these methods, but effect from these manipulations only 30–40% from the 1–2 year. The prostate tissue is then heated to the about 45–65 degree. A cooling system ensures that the heat from the coil does not damage other tissue, and the temperature of the tissue is monitored using the device that is inserted into the back pressure. The damaged prostate swells initially, but the chinks. In this picture, we can see methodical urethral thermotherapy in our department. Laser therapy. It's used to destroy some of the prostate tissue by intestinal local head. The procedure is carried out under the journal and takes about 20 minutes. A laser probe is inserted through the urethra, and the prostate tissue is then treated with the laser. Some of the tissue that is destroyed is removed during the operation, but most is washed away afterwards in the urine over the number of months. High intestinal focus ultrasound therapy also used. The procedure is carried out under the general anesthesia and take about 30 minutes. Now we can see a film from this, how we use. It's very good methodical without bleeding. Technique is very good. Holmium laser ablation.
Holmium laser enucleation of the prostate is an emerging technique for the surgical management of BPH. There are a number of advantages over the resection technique. The operating time is decreased. It is conceptually simpler and tissue quality is improved. Large prostates can be safely tackled, making it the endourologic equivalent of open prostatectomy. The 80 or 100 watt holmium laser is necessary and the tissue is removed with mechanical soft tissue morcellator. This morcellator has reciprocating blades and uses high-powered suction to hold the tissue fragments.
It's operation room. First of all, visual control, cystoscopy.
The patient is a 72-year-old man who has failed a trial of medication, is clinically obstructed, and has a measured prostate volume of 74 cc's. 58 grams of benign tissue was retrieved. Here we see the enlarged medium lobe extending back to the verumontanum.
Seminal vesicle, you can see.
Large occlusive vascular lateral lobes can also be seen. The procedure commences with bilateral bladder neck incisions, which define the amount of tissue to be removed from the floor of the prostatic fossa. These divide the circular bladder neck fibers from the urethral orifices down to the veru. They should have a smooth base and cleanly defined edges to aid in subsequent median and lateral lobe enucleation.
You can see a scan of these operations where I use the fast incision.
Incisions commence at the bladder neck and are deepened down through the circular fibers. Once the capsule has been reached, the incision can be extended out laterally to commence undermining of both the median and lateral lobes. Once both incisions have been created, the median lobe between them is enucleated. The two incisions are joined just above the veru, and the fiber is moved from side to side to undermine the lobe in a retrograde direction. This is continued until the median lobe can be delivered back into the bladder. The two incisions are first connected, and this is deepened down to join the two incisions which have defined the plane of the enucleation. This dissection continues back to the bladder neck. Here we can see that there is quite a large fragment of tissue which will need to be retrieved later by tissue morcellation. It is released back into the bladder, where it remains until the lateral lobes have been enucleated. Once the median lobe has been removed, each lateral lobe is tackled in turn. The enucleation commences at the apex, where the plane of the surgical capsule is found. The instrument is then rotated to the 12 o'clock position, and the upper margin of the lateral lobe is released. The lower border of the lateral lobe is first defined, and the lower attachments of the lateral lobe to the surgical capsules are released.
You can see that
Here we can clearly
without
see the
bleeding.
surgical capsule and the attaching fibers. Once the 12 o'clock incision has been performed, this is extended out laterally, and the upper margin of the lateral lobe is gradually released, peeling it off the surgical capsule. This commences at the bladder neck and gradually extends back towards the apex. Once the upper and lower margins have been released, the two incisions can then be joined at the apex, and the lobe released in a retrograde direction, staying precisely on the surgical capsule. Once both lobes have been removed, hemostasis is obtained, and any residual tissue is removed. Here we can see the bridge of tissue connecting the upper and lower incisions, which is to be divided, commencing the enucleation. The attachments between the adenoma and the surgical capsule, which need to be incised with the laser, can clearly be seen. The enucleation continues from above and from below as the lobe is peeled back towards the bladder. The lobe can then be gradually released by incising the last remaining attachments. The capsule can now be seen, and a smooth barrel-shaped cavity conforming to the surgical capsule is obtained. This results in unobstructed voiding with little chance of regrowth of the residual adenoma.
We can see a good diameter of the prostatic part of the urethra. Without compressions, we remove all tissue, without bleeding, very good effect.
It is very important prior to morcellation that good hemostasis is obtained so that visibility is excellent. The fragments are attracted by suction and then the morcellator activated. Following morcellation, the bladder is inspected for remaining fragments and mucosal injury. The morcellator includes a graduated footpiece for both suction and morcellation. The fragments are drawn into the blades and the blades activated. It is important to be able to see the bladder around the fragment and to be able to move the fragment freely. The morcellator can then be used to mop up any remaining smaller fragments once the three main lobes have been extracted.
We remove all fragments. And after
The
that, the
catheter
doctor
is then
passes
inserted, and because of the properties of the holmium
catheter
laser,
fully.
the effluent is usually clear.
Clear water, that's why without
Holmium
bleeding.
enucleation results in significant advantages for both the patient and the surgeon, and will become a new standard for the surgical management of benign prostatic hyperplasia.
Okay, continue. Now I want to start some words about prostate cancer. In this picture we can see the prostate cancer incidence per 100,000 standard populations, and we can see that the level of patient with the black and white populations more than in the Asian populations. Top 10 causes of death in men over age 45. We can see that the prostate cancer in 5th place in disease in men of after 45-year-old. First of all, the heart disease, lung cancer, stroke, emphysema, and after prostate cancer. In this picture we can see the level of prostate cancer in the different countries. USA, Sweden, Canada, and 95% of prostate cancer is diagnosed in men between 45 to 89 years of age, with a median age diagnosis of 72 years. What classifications? We use TNM classification cancer of the prostate. TX, primary tumor cannot be assessed. T0, no evidence of primary tumor. T1, clinically inapparent tumor not palpable or visible by imaging. T1A, tumor incident histological in 5% or less of tissue resected. T1B, tumor incidental histological finding in more than 5% of tissue resected. T1C, tumor identified by needle biopsy because of prostate-specific antigens. That's why we never use, if you use digital rectal examinations, put T1, only after resection of the tissue or after biopsy. T2, tumor confined within the prostate. We divide to the T2A, tumor involves one lobe. In this picture we can see T2B, tumor involves both lobes. T3, tumor extends through the prostate capsule. We divide T3A, extracapsular extensions, uni or bilateral, and T3B, tumor invites seminal vesicle. If we invite seminal vesicle. T4, it's fixed or invades Jane's structure or other organs, seminal vesicles, bladder neck, external sphincter, rectum, levator, and the pelvic wall. First of all, we take PSA test, but after PSA test we use digital rectal examinations. What we palpable? We palpable hardly consistent, maybe. Not moving the rectum above the cancer, deformation the prostate gland, and specific from the cancer prostate mass. If we use digital rectal examinations, PSA test, and ultrasound examination, we suspect cancer of the prostate, but we never put that we have hardly consistent the level, for example, prostate-specific antigens 9, 10, 12. We never put that the patients have cancer, only after histological examinations. If you use ultrasound examinations, give us information from the size of the prostate, maybe from the some part the hardly consistent. If you use Dopplerography, additional vascularization of this part, we only suspect tumor mass. If you use CT or MRI, it's very good methodical for diagnostic cancer of the prostate because we have informations from the tissue, from the lymphatical nodes, and other organs. Now, if you use spiral MRI and other modifications from the T3D, we have very good information from this pathology. Sometimes, without specific clinic, we find metastases in the lung, in the liver, bone of the pelvis. You can see metastases in the lung, in the pelvis bones if you use X-ray, plain film. And after that, we find what's the cause of this metastasis. Prostate-specific antigens, once more repeat that the normal before 4, it's average, but sometimes we have gray zone between 4 to 10 nanograms per milliliters, about 25% the probability of cancer. But sometimes, I said, it's independent from the inflammatory disease. If we use digital rectal examinations, we never use PSA test because the level increase. That's why I recommended it after 2-3 weeks after digital rectal examinations or before digital rectal examinations. If the level prostate-specific antigen more than 10, more than 50% of patients will find cancer of the prostate. We use free prostate-specific antigens, orals, and others. Biopsy. If we have hardly consistent, if we have increased level prostate-specific antigens, it's indication to transrectal or transperineal biopsy. We take biopsy from the 6 to 12 place because sometimes if you use only 1-2 position place, we sometimes never find the atypical tissue. That's why from the recommendations European and American Associated of Urology use from the 12 positions. Now we can see film how we use transperineum or transrectal biopsy. We use from the 6 to 12 place.
Has recommended an exam of your prostate with a transrectal ultrasound and prostate biopsy. Before we talk about this procedure, let's review some information about the prostate and why these tests may be necessary. The prostate is located under the bladder and behind the penis. It is
This
a
is the
walnut-sized
anatomy where
gland that is
situated
part
our
of the male
prostate and
reproductive
how we
system.
use this method.
It helps make semen. The urethra is a tube that carries both urine and semen to the penis. It passes through the prostate, which surrounds it like a donut. If you are scheduled for this procedure, your surgeon is concerned that you may have prostate cancer. Prostate cancer is the most common cancer found in men. At most risk are men age 50 and older and those with a family history, especially a father or brother with prostate cancer. But at highest risk are African American men and men over age 70. Usually there are no early signs of prostate cancer, but some men have problems with urination or pain that warn a physician that more testing is needed.
If the level
Prostate
PSA
cancer
test
screening
more
can
than
help
4
physicians
nanogram
find
per
prostate
liter.
cancer early before a patient has problems and include the digital rectal exam, or DRE, where a physician examines the prostate for lumps by placing a gloved finger in a man's rectum, and prostate-specific antigen, or PSA, is a blood test ordered for some men based on their age and risk factors. Routine PSA testing is not recommended after age 70. A prostate ultrasound with biopsies is done to test for cancer when a nodule or lump is felt. It is also done for a high PSA and for some problems, especially with urination, that can be a sign of prostate cancer. With an ultrasound, Your surgeon is able to scan and measure the prostate without X-rays or radiation. The ultrasound also guides the needle used to biopsy your prostate. The tissue biopsies are sent to a pathology lab for examination. The
Only
next
after
steps for your
histological
care are
examinations we
discussed
put
after the
cancer of the
procedure and with
prostate.
the final lab results. This may take 1 to 2 weeks. If cancer is found, the lab will give the tumor a number called a Gleason score, which is a grade of how abnormal or aggressive the tumor cells look. DNA gene testing is commonly done on the tumor cells as a new way to measure how aggressive the tumor is. This is different than a cancer stage, which is based on where, how large, and if the tumor has spread. Treatment decisions for prostate cancer are based on many factors, including a patient's age and general health, the cancer Gleason score, DNA results, and stage. A biopsy can be false negative. That means the biopsies did not find prostate cancer that was there. 30% of men with prostate cancer, about 1 in 3, will have normal biopsy results from the first procedure. A second procedure with more biopsies is done to search for prostate cancer if a PSA stays high and cancer is strongly suspected but was not found with the first set of biopsies. Sometimes MRI, magnetic resonance imaging technology, is used with the ultrasound to help find or target a tumor for biopsy. Ultrasound-guided prostate biopsy tends to be a short procedure, available at many hospitals, and is the most common procedure used to biopsy the prostate. MRI technology uses magnetic coils to get detailed information about the prostate and possible cancer. MRI is very expensive, takes longer to do, is newer and still being studied, is less available, but is helpful in managing difficult cases. Now let's talk a little more about what happens during a transrectal ultrasound and prostate biopsy. To start, you are positioned comfortably. Most patients are awake for this procedure. An ultrasound probe is coated with lubricant gel and gently placed into your rectum. The gel helps the probe to be more comfortable for you and is needed to get clear ultrasound pictures. The size and shape of the prostate is checked and measured by gently moving the probe near the prostate. Numbing medication is injected near the prostate to decrease the discomfort of the biopsies. The ultrasound probe is used to guide a needle biopsy device to take about 12 tiny pieces of prostate tissue. You will hear a snapping sound with each biopsy. After the biopsies, the ultrasound probe and needle are removed. This procedure is done as an outpatient. That means you will go home the same day as the procedure.
Okay. Treatment. After histological examinations, if we find cancer of the prostate, treatment independent from the stage. If we have early stage 1, stage 2, it's a recommendation to radical prostatectomy, open radical prostatectomy, transperineum laparoscopic, or by the robot Da Vinci. More than 50 to 60% we use radical prostatectomy if we have clinical stage 2. 32% is radiation therapy, and 14–15% observations. If we have severe stage T3, T4, we use radical prostatectomy only 5–7%. Androgens therapy more than 60–70%, observation 7%, and 21 radiations, because cancer of the prostate sensitivity to the hormone. We must remove the hormone, reproduce our hormone in the testes. That's why we use enucleation or epididymiectomy, and also block, because 10% of all testosterone are produced by the adrenal gland. That's why we prescribe specific drugs. Resection of the prostate, if we have T3, T4 from the urinations, from the dilatation, the prostatic part of the urethra, sometimes we use transurethral resections from the good side. And hormone therapy, X-ray therapy. Also, we prescribe X-ray therapy. It's a very good effects from the cancer of the prostate in the severe stage. And also we prescribe if we have metastasis. And very good effects and very new, it's a modern methods from the treatment cancer of the prostate. It's a modifications that called a robot Da Vinci. The robot help the doctors remove the prostate gland without tremor. The level of bleeding decrease. That's why it's very good modern methods from the treatment cancer of the prostate. I want to say once more, repeat that if we have problem with the lower urinary tract, first of all, we suspect cancer. We use prostate-specific antigens. We use digital rectal examinations. We use transrectal ultrasound investigations, MRI, and if we suspect, if we have gray zone, the level increase and maybe increase every year, it's indication to biopsy. Because if we find cancer of the prostate in the early stage, it's a good effect from the treatment, and if we compare in the severe stage, the 5-year survival increase if we find T1, T2 stage cancer of the prostate. I also practice from the robot Da Vinci. It's a very good apparat, and I think in the future we will have from the Albay clinic. Okay, at the finish of our lecture, I want that we will see very interesting film, robotic assisted laparoscopic radical prostatectomy. I said that the robot Da Vinci helped to use these operations. Now we can see a very interesting film. It's a Harvard film where the robot and doctor want to use a radical prostatectomy. Okay.
Hi, I'm Adam Stewart-Kywell, Chief of Urology at the Brigham and Women's Hospital. Today we're going to talk about robotic-assisted laparoscopic radical prostatectomy. Our patient today is a 57-year-old male with no family history of prostate cancer, no other significant medical problems. He has normal erectile function and no problem with incontinence. He's got a DRE, digital rectal exam, which shows a positive nodule. His PSA checked at that time was found to be 11.1.
We see all information from these patients and what indication to radical prostatectomy.
Cores were positive on the right side in 3 cores. Gleason 7 cancer in 1 of them, demonstrating 15%
before we have histological examinations and the sun score.
Cancer with a Gleason 6. He also had a small amount of cancer on the left side, again showing Gleason 6 cancer, less than 5% of that core. All treatment options were discussed with this patient. These included watchful waiting, which involves following the patient closely, however not treating him with curative intent, so simply observing his cancer. It also included discussing active surveillance, which is slightly different. That involves following the patient very closely with serial PSAs and actually repeating the biopsy at periodic intervals to look to see whether the cancer has become more aggressive. If the cancer ever does look more aggressive, either due to a rapidly rising PSA or due to changes in the biopsy, then the patient would be treated with curative intent with either radiation or surgery. Radiation therapy, this includes both brachytherapy or seed therapy and external beam radiation therapy. And lastly, radical prostatectomy, both robotic and open approaches. At Brigham and Women's Hospital, we believe strongly that patients that have more aggressive cancer, in this case a patient who has a Gleason 7 cancer, really need to be treated with aggressive therapy. And therefore, after a long discussion with the patient, he elected to undergo robotic prostatectomy. As part of our discussion, it was important to discuss the side effects of treatment, and in particular the pain associated with an open operation. And the patient felt strongly that he wanted to have an operation which actually provided fewer side effects and allowed a more rapid recovery. This is how we perform a robotic-assisted laparoscopic radical prostatectomy at Brigham and Women's Hospital. We're already in the peritoneal cavity, and our first task is to expose the prostate. In my left hand is a PK. That's an electrocautery device that delivers bipolar current and can be used to provide traction in addition. In my right hand is a pair of scissors that's also hooked up to electrocautery. This can be used in order to both cut and cauterize tissues and vessels. As I stated, the first thing we need to do is drop the bladder. What that involves doing is incising the urachus and incising the peritoneal reflection on both the right and left side. By doing this, we'll be able to pull the bladder down in order to expose where the prostate lies, which is just under the pubic symphysis and just in front of the bladder. As we pull down on the urachus, we're going to start to see how the plane is being developed.
Step by
There's
step,
flimsy tissue
without
here, which
bleeding.
can be incised either using electrocautery or using a pair of scissors. You'll notice much of it just comes down easily with just a little pulling and prodding. As we develop this space, we'll quickly get down to where the prostate is located. So here you can see the prostate, which is on the left of your screen. It's difficult to see in large part because there's a large amount of fat overlying it. So actually our first task is to remove the adipose and fat tissue and lymphatic tissue that overlies the prostate. I'm now on the left side, pulling the fat over towards the midline where the prostate actually lies. This fat occasionally contains lymphatic tissue that's important in the drainage of the prostate, but by and large simply contains adipose tissue that is simply getting in our way and making it more
Incisions
difficult
and
for us to do a
coagulation,
precise
step by
operation.
step.
You can see the bipolar in use here, effectively cauterizing rather large vessels. And you'll notice when I transect it, there's absolutely no bleeding. That's clearly one of the advantages of the robotic approach, in that it provides a very good operation with minimal blood loss, which is significantly less than its open counterpart. So the prostate is hidden by the endopelvic fascia, so we need to incise it, and you can see me doing this on the left-hand side here. So the prostate is just to the left of your screen. The pubic symphysis can be visualized anteriorly, sort of white with some blood vessels coursing over it. What you can see me doing here is incising the endopelvic fascia using both sharp dissection and electrocautery. And on the left-hand side, you can actually see the prostate. So here I'm incising the endopelvic fascia on the left side. Again, doing exactly the same thing I did on the right. You can see the prostate starting to appear as sort of fleshy colored tissue under the white of the prostate. The sucker is actually pointing at the prostate at the current time. Again, these muscle fibers are attached to the prostate, and we need to tease them off. Once we have removed or incised the endopelvic fascia, we need to tie up the dorsal venous complex. So the dorsal venous complex runs under the pubic symphysis to the prostate, and a large amount of blood vessels flow through this. Obviously, when we transect these, they will
To have
bleed
a big
significantly if we didn't tie
diameter
them
of
off.
the vessels,
I think
to
one of the
use
things you can see right
ligations
here very
in
nicely
these
with the robot
situations.
is the precise way that we can place the sutures in order to tie up the dorsal venous complex. We use a figure 8 because this provides better hemostasis than a simple suture. I think you can really see how nicely we can place and precisely we can place the needle. Once we place the needle, it's going to be important to tie off the dorsal venous complex. So I think that we're going to be doing that right here. And what you can see is how nicely you can precisely and rapidly place the suture and tie this off in a nice tight way. And when we come back later, because we're not going to transect the dorsal venous complex now, when we come back later, you'll see that there'll be next to no bleeding from the dorsal venous complex. We need to cinch this down tightly, then complete our knot. Now, once we have completed tying up the dorsal venous complex, we're going to turn our attention to the bladder neck. So this is the junction between where the prostate and the bladder sit. So you can see me starting to incise this here. We've determined exactly where this lies. Our goal is to get into the groove between the prostate and the bladder. We can see here is me furthering my incision, and you can see that small opening in the middle is me actually entering the bladder. You can see the Foley catheter in blue in the middle of your screen. I'm now going to grasp this and pull this up anteriorly and provide traction to elevate the prostate. The pink in the middle of your screen is actually the bladder. You can see I'm incising the posterior aspect of the bladder so to enter the space posterior to the prostate between the rectum and the prostate. You can't see the ureteral orifices. They are within the bladder, and we don't actually see those because they're so far away from where we're actually making our incision. If we had to make a bigger incision, we would actually look for them quite carefully and sometimes actually give dye in order to make sure that we identify them. So now I'm incising this posterior aspect, the area between the prostate and the bladder, in order to expose the seminal vesicles and the ampullary portion of the vas. These are two structures that are very important in reproduction. They actually carry the sperm from the testicles to the prostate and then allow us to be fertile. Here you can see me grasping the ampullary portion of the vas, the tube again that carries the sperm from the testicle to the prostate. What I'm trying to do is isolate this tube so that I can transect it. And you can see me pulling it up here, grasping it, and then I'll transect it with the electrocautery device. Again, these are structures that lie behind the prostate and the bladder, and we've accessed them by incising the posterior plate, the plate behind the bladder, to get underneath the prostate. So here's the left ampullary portion of the vas being identified and transected in an identical manner. So the next part of our procedure is to isolate the seminal vesicles and dissect them free. A key part of this procedure is try to limit the use of electrocautery in this area, so we use the bipolar predominantly in order to bipolar actually perforating blood vessels. The reason for this is because the nerves that control ejaculatory function actually lie in close proximity to the seminal vesicles, so we don't want to injure them inadvertently by using electrocautery. You can see me grasping the seminal vesicle and pulling it up and to the left, and then essentially just teasing the tissue off the seminal vesicle, trying to identify the blood vessels. So now what we need to do is dissect the neurovascular bundle off of the prostate. This is done very carefully in a completely athermic technique. We do everything we can not to use any electrocautery in this area because we do not want to damage the nerves. This is the neurovascular bundle actually on the left-hand side. So the prostate is to the right. The pelvic sidewall is to the left. The scissors are actually coming across the prostate and dissecting the neurovascular bundle, which is being retracted to the left by the PK. The goal is to get under the prostate and dissect the nerves as well as the vessels off of the prostate to the undersurface of the prostate. So the prostate is being pulled slightly to the right by my scissors, and the PK device is being used in order to continue the dissection parallel to the prostate and underneath it. So now we just have the pedicle holding the prostate, and this is usually taken with a wet clip. The reason why we use wet clips is, again, because these are athermic. They don't deliver any energy, so they're much less likely to damage the neurovascular bundle. Once we clip them, then we just cut it with cool scissors. Again, doing our best to do everything we can to have patients maintain normal erectile function after the operation. You can see the seminal vesicles dissected free just off to the right of your screen. Once we place the wet clips, we try and get into this plane that exists between the prostate and the neurovascular bundle. And when we're in the right plane, you can actually just tease the neurovascular bundle and the vessels off of the prostate without any difficulty. Now, occasionally there are some attachments, and that's what you're seeing here. This is a very firm attachment to the prostate. I could take this with the PK, but I prefer not to, again, because my concern is that I'm going to cause thermal damage to the neurovascular bundle. I could just cut it, but again, my concern then is that it would lead to significant bleeding, since often there are small blood vessels in this. So instead, I use the PK and the scissors in order to dissect this attachment out very carefully, and then I'm going to have my assistant bring in a wet clip, a plastic clip, that will be used in order to clip this small perforating vessel. My assistant can place this quite precisely, just around this particular vascular structure, including none of the other structures that are important. And in this way, we maintain a precise operation, controlling the blood vessels and don't injure the neurovascular bundle. So obviously we did this on the left side, now we need to do it on the right. So the prostate is now to the left of your screen. On the right-hand side of your screen is the body sidewall. And you can see me pulling the neurovascular bundle to the right-hand side, using the scissors and the PK in order to gently dissect the neurovascular bundle off of the prostate all the way back towards the apex. Again, in exactly the same way as the left-hand side, we then use a wet clip, not electrocautery, on the pedicle. Again, my system places this very precisely. And then I use cold scissors in order to cut this. Again, I know I emphasize this a lot, but our goal is to do everything we can in order to maintain normal erectile function in our patients following this operation. So again, once we can elevate the prostate, you can see how precisely we can tease. We can precisely dissect off the neurovascular bundle without actually injuring the nerves that are important for erections. So once we've completed on both sides, the prostate is now only really held by the urethra. So I'm transecting the urethra here. As we deepen this, I'm going to stop using electrocautery and I'm going to start using sharp dissection. Again, one of the other complications that have been associated with radical prostatectomy is a stricture between the urethra and the bladder after the prostate has been removed. And again, by using sharp dissection without electrocautery, we may actually have a slightly higher bleeding, but the vascular inflow to these important structures is preserved, and therefore it decreases our stricture rate. So that you can see me here using sharp dissection in order to dissect the urethra and expose the Foley catheter. You're going to see it in a second in blue. Notice there is a little more bleeding here as a result of using the sharp dissection, so I use some precise electrocautery in order to control that, but don't use the cautery nearly as much as when I'm in regions of the body where I'm not as concerned about either the neurovascular bundle or the patient's ability to heal.
Sometimes
So
we
second,
have very
we're going to see
profuse
the blue.
bleeding.
There it is. So that's the
It may
Foley
be
catheter, which is being
complications
passed
to
through the penis,
be changed to the
through
open
the urethra and into
operations
the
and stop
prostate.
from the
Allows
bleeding.
us to demarcate exactly where the urethra is. You can see me here passing an instrument underneath the posterior aspect of the urethra. I've only cut the anterior part of it. Now I have to cut the posterior part
The
of it.
urethra, you
Again, I do
can
that
see
sharply,
catheter
not
fully.
with electrocautery, to do everything I can in order to decrease the risk of developing a stricture after the surgery. There's only a small amount of tissue left here, which is being cut sharply. I'm now remote from the urethra, so I can feel a little more comfortable using cautery if need be. The prostate is now free and can be extracted from the patient's abdomen. This is a very nice shot of the neurovascular bundles. They've clearly been preserved on both the right and left side, and we've achieved our goal of maximizing the patient's ability to achieve erection after the operation. The next part of the operation is to dissect off the lymphatic tissue, which we can then remove and look to see if there's any metastatic deposits in the lymph nodes. I feel this is an important part of the operation because occasionally we do find metastatic disease. As we tease this off the lateral aspect of the patient, we need to identify the nerves. These are not nerves that control erection. These are nerves that control the ability of the patient's legs
You
to move.
understand that
The
you use the
obturator nerve.
innervations, you will
And
have
you can see it,
impotence,
right
but
approximately
sometimes
where the
you
scissors
use
are now.
operations that
We've
not
carefully
destroy the
identified it
nerves,
and are now
pudentus.
cutting the lymphatic tissue off of this area, which we will then send to pathology for more formal analysis to ensure the patient does not indeed have metastatic disease. The next part of the procedure is to actually perform the anastomosis. And the first part of that is to suture the rectourethralis muscle to Denambia's fascia. So Denambia's fascia is some very tough fascia that I have in my needle right now, which lies underneath the bladder. The rectourethralis muscle is very tough fascia that lies underneath the urethra. And the idea behind putting this suture in is it allows us to pull the bladder and the urethra in close approximation. And it allows us then to do our anastomosis between the bladder and the urethra in a tension-free environment. The reason this is important is because tension decreases the ability of this to heal well, increases our stricture rate, potentially increases our leak rate, where there's actually a leak between the bladder and the urethra, which takes some time to heal. Notice one of the real advantages of the robot is the precise way that we can place these needles. This is because the wrist can actually articulate. I did many of these operations laparoscopically before I started doing them robotically, and one of the hardest things to do was to actually be able to sew laparoscopically. We're now pulling on the suture and pulling the bladder down into close approximation with the urethra. This is the same suture I placed previously, and once we get these into close approximation, we're ready to actually do our anastomosis. So now I'm starting to perform the anastomosis. This is a monocrystal suture I have in my hand, which is a very delicate but strong suture. I'm placing this in the bladder. You can see the needle coming out of the bladder mucosa on the right side of your screen. This is the right side of the bladder that we're actually beginning our anastomosis. Again, as I emphasized earlier, I think one of the really nice things about the Da Vinci robot is our ability to sew, place these needles very carefully in very tight spaces, which I think you can appreciate by watching how I'm doing
Performed
this.
new anastomosis, you can
So
say.
again, I just placed the needle in the urethra. You can tell that because of the blue Foley catheter that's coming out of the urethra. We now pull this down, start to pull the bladder into closer approximation to the urethra. We'll now have to place our next bite into the bladder. You can see us placing it through the muscle of the bladder and then coming out through the mucosa. Again, notice how precisely we can place this at the very edge of the mucosa. We'll now place another sutures in the urethra and back in the bladder again, and then back in the urethra until we've completed the posterior plate. So I'm now pulling down on that suture in order to pull the posterior aspect of the bladder into close approximation with the posterior aspect of the urethra. I'm now completing the left side of my anastomosis. You can see now I have a red Foley catheter in place. You can see me placing this needle through the urethra. One thing I'd like to emphasize here is notice I'm retracting the neurovascular bundle laterally, and I'm placing the needle very precisely just medial to the neurovascular bundle. In this way, we don't accidentally or inadvertently injure the neurovascular bundle while we're doing our anastomosis. So we can injure it not only by cautery, but also by placing our needles through it. And I think, again, one of the nice things about this robotic system is that we're able to place the needles very precisely and thereby avoid inadvertently injuring something that we obviously don't want to injure. So here I am completing the left side of my anastomosis. I'm running the needle up through the bladder. That's where I just placed the last stitch. And then I place it in the urethra. And as you can see, the rapidity and precision that I can place these needles. Once we complete this, I'm going to start doing the same thing on the right-hand side. Again, we'll have completed half of our anastomosis. You can now see me on the right-hand side placing a needle. This was a double-armed needle, so I ran one arm of the needle up towards the left-hand side. I'm running the second arm of the needle up towards the right-hand side. Again, I place this needle very precisely so I get muscle and then just a tiny bit of mucosa. We want to get a mucosal to mucosal anastomosis, where we include the mucosa in the urethra and the mucosa of the bladder, and they're in close approximation. Again, this improves healing. Again, you can see the precise way that I can place this needle. The neurovascular bundle you can see off to the left of your screen, off to the right of your screen, and I can place this needle very precisely, not actually injuring the neurovascular bundle. Again, continuing the anastomosis anteriorly. You can see I've included a nice bite of mucosa.
posteriorly part with fusion.
Notice how nicely the bladder is coming down to the urethra. There's that pink or orange catheter that is lying between the urethra and the bladder. We're going to leave that in place at the end of the operation. We leave that in for about 7 days in order to allow the patient to heal. Now we pull it all down. We're pulling on the stitch in order to complete our anastomosis. The urethra and the bladder mucosa are now in tight, close approximation. Our next job is going to be to actually tie. You can see again how quickly and carefully we can identify the sutures and place a rather elegant knot. Again, to emphasize, this kind of tying was very difficult when we did this straight laparoscopically, and the robot really makes this much easier and therefore facilitates the precision of the operation, the speed of the operation, and the subsequent functional outcomes to the patient. Once we've completed our anastomosis, we then test it by filling it with 60 to 120 cc's of saline. You can see in this case the bladder expanding and then decreasing, and there's no evidence of any leak,
Filling
indicating we have
bladder
a watertight anastomosis.
control if you have good anastomosis or not. Okay, thanks.
So the patient's clinical outcome was quite good. His pathology showed a reasonably aggressive tumor, about 1.4 centimeters in its greatest dimension. Its Gleason score was 6, involving both lobes, so it was bilateral. So this was staged as a T2C N0M0 cancer.
Patients
He
will
had
have
negative
good
margins.
reactions
His lymph
after
nodes were
this
negative.
operation.
His
You can
seminal
see.
vesicles were negative. So he had excellent pathology. At 5 weeks follow-up, this patient is doing quite well. He's back to his normal level of activity without any pain or discomfort. His PSA is undetectable. He's completely continent, not requiring any pads. And lastly, his erections are 5 out of 10, which he estimates are good enough for penetration. This is obviously quite early in the patient's follow-up. However, these good functional results so soon after surgery indicate that the patient is probably going to do quite well with longer follow-up. Thank you very much for watching the video. I hope it was helpful. If you have any questions, please feel free to contact us at the number listed below.
Thank you for our colleague from the good film. Okay.